Hello, I'm Dr. Andrea Janeková.
And I'm Francesco Carones. Welcome to this first episode of the three-part independent medical education video interview series on simultaneous vision IOL.
In this episode, we are focusing on something that plays a critical role in every IOL.
Then we will discuss practical ways to optimize the ocular surface before surgery. It's a key step in avoiding refractive errors and protecting outcomes.
Let's start with this data point from the 2024 ESCRS Clinical Trend Survey. The question was, how significantly does the presence of mild to moderate dry eye impact the accuracy of the keratometry readings and the IOL calculations? And nearly 25% of surgeons believe that the mild to moderate dry eye only somewhat or not very significantly affects their result. Does this match what you are seeing in your own clinical practice?
Well, it does and it does not. We know that the impact of dry eye is significant in way more than that cases as a percentage. And especially when dealing with presbyopia-correcting IOL, let's say full range of focus, full range of vision IOLs, we really want to make sure that our assessment is perfect because these lenses are still a little bit of critical on the outcomes. So you have to be plano and without astigmatism to get the best results.
I think there's a little diversity between the evidence-based data and the everyday workflow in the clinic. And we all know that the severe dry eye and the affected cornea, which can be seen at the slit lamp, really affects the keratometry. But the problem is the moderate to mild symptoms and to identify the right patient with that problems and to set a proper examination in the workflow to identify that cases. What do you think is the risk of underestimating the dry eye at diagnostic therapy?
Well, there are two risks associated in my idea. The first one is that you're going to be less accurate on the refractive results after surgery, leading to all the consequences. But the second, maybe most important risk is the fact that these patients are complaining after surgery, both in terms of efficiency of vision and in terms of individual symptoms. Because we know that very often those undiagnosed cases may create a lot of problems. So I really think that the issue related to dry eye, even if it is mild or moderate, has to be addressed before surgery.
Yeah, and it really impacts the overall satisfaction after the surgery. Why do you think that the impact of dry eye is still underestimated by many surgeons despite the evidence-based papers?
Well, I think that most of the reason goes on the fact that many surgeons do not really see the reasons for this accuracy and this need to fix dry eye before surgery. Maybe this is because they do not have a full approach as regards presbyopia-correcting IOL. It may be because they implant either of IOLs only, which are more forgiving. We focus on presbyopia-correcting IOLs as a standard in most of our cases, so I think that makes a difference.
Yeah, definitely the refractive cases and refractive lens exchange need much more attention to managing the dry eye, even though very mild. And that brings us to the next step, how to screen, stabilize and streamline the ocular surface to optimize it in a real-world practice. So what diagnostic tools do you use in your practice to confirm the ocular surface issues?
We do an ocular workup which involves what is done on a routine basis with the microscope, so the tear film evaluation, the meibomian gland evaluation, all of that. But additionally, we do osmolarity testing in all eyes. We also assess the presence of inflammatory subclinical reactions through the MMP9 evaluation. I think it's better to set up a protocol as to screen everybody who is going to go through surgery.
Yeah, definitely. I agree with you.
How do you fit treatment into your pre-op workflow without really delaying this process of setting up and measuring everything too much?
The best is to set the treatment immediately when I are having the patient at my office And usually in mild to moderate cases, I recommend the preservative-free lacrims, sometimes steroids, and if there is a need for meibomian gland therapy, I explain the patient the process and I invite him, let's say, in 3 weeks to check the ocular surface and repeat the measurement.
We cannot really forget the conversation with the patient. When they understand that surface treatment leads to better results, they are more likely to follow through.
When you decide to delay surgery, to treat the ocular surface, first, how do you personally explain to patient that delaying of surgery is something what is needed and what can get better results for him?
Yeah, well, actually, most of the patients that I see are coming to my practice because they know that we provide spectacle independence solutions and they are there to meet that goal. So when discussing with the patients that the pre-existing condition like dry eye or even non-symptomatic dry eye may lead to a lower possibility to really giving them spectacle independence, they do understand and they do follow our indications. I think that it is critical to communicate that garbage in, garbage out. So we want to have a very nice measurements as to avoid outliers after surgery.
Yeah, great. I usually explain that the tear film is something like a camera, and you can have very expensive camera, but you won't capture a bright picture if the lens is cloudy.
Exactly. And we do not just treat a dry eye to make the eye more comfortable. That's the most important point.
Yeah. Just to explain patient what is the dry eye, even if it's mild, it helps me with the post-operative care because the patient already understands that maybe there is some kind of dry eye. He should use more artificial drops even before the surgery and probably after. So that helps me with the overall satisfaction in my patient, especially in the presbyopia. Thank you for joining us for this independent medical education discussion on ocular surface optimization in refractive IOLs. And we hope that this insight help you to refine your preoperative approach and achieve a more predictable results for you, us, and our patients.
Thank you.
Thank you.